Okay, good afternoon. This is the What's New in Prostate Cancer Treatment. We're all in the right room. I was supposed to say that. Okay, very good. My name's Mike Philbin. I'm a volunteer with FORCE. I'm a peer navigator. I help run the men's support group. I'm also a social media ambassador, research advocate. I think I've almost got every single FORCE thing you can volunteer I do for. So I'm a 10-year prostate cancer survivor. I was diagnosed at 52. I found out about my BRCA2 mutation back in 2020, but I had a family history, so I was already, on top of all my screening and stuff. So I like to think of myself as kind of an example of being a man in a high-risk group that early screening caught the cancer early, where I could be quote-unquote cured, for lack of a better word. But like I said, my PSA test is next week, so that's why I just knocked on wood. Just want to remind you, fill out the evaluations in the conference app. We would appreciate that. There's going to be a break immediately following the session, and just asking to leave your questions till the end and come up to the microphone. So our speaker is Dr. Veda Giri. Dr. Giri is a professor of medicine at Yale University and is a medical oncologist who specializes in clinical cancer genetics. She's the director of the Cancer Genetics and Prevention Program and director of the Early Onset Cancer Program at Yale Cancer Center and Smilow Cancer Hospital. Her research focus has been in developing the field of genetic testing for prostate cancer with a dedication to reducing disparities. She contributes her expertise on several national committees such as NCCN, NCI, and ASCO. So, Dr. Giri?
Thank you very much. Thank you. Thanks, everyone. Thanks for coming on this beautiful afternoon. And, we have quite a bit of time today, this afternoon. So I don't know if, I'm trying not to, we should leave time open for questions. And if we want to make this as interactive, please feel free. If you want to move to the front, please feel free. And because the topic is rather broad and we had some time, I tried to make it such that it could be potentially relatable, or anyone from any background could gain something from this presentation. So some of it is a little bit sciencey, some of it is much more geared towards like public awareness and things like that. So just to know who's in the audience, just by show of hands, can I just see if there's actual healthcare providers? Great. Genetic counselors, genetics experts? Great. Patient advocates? Yes, wonderful. Community members? And I'm missing anyone else? Yeah, everyone's a community member, right? Guidelines, any other types of backgrounds that I'm missing, just so that I know I can tailor this a little bit as I'm speaking. Anyone that I'm missing?
I'm a breast cancer survivor.
Oh, okay, wonderful. Thank you. All right. Okay, well, we'll go ahead and go forward. So my topic that I was told to review is what's new in prostate cancer treatment. And just to start off with, I have no disclosures that are relevant to this presentation. To really kind of comprehensively cover and understand what's new in prostate cancer treatment, I think it's really important to cover a bit of how this fits into the context of genetic testing and the understanding of genetics in prostate cancer. So we'll cover some of these things in more or less detail as we go through the presentation. So how did genetic testing evolve for prostate cancer? What are the current genetic testing criteria when it comes to genetic testing for prostate cancer? This has also been evolving. Understanding genetic testing, what it means to have genetic testing, and how this is implemented in clinical practice. And then really get into the impact of genetics on prostate cancer clinical care, treatment, data from trials, and things like that. And then I thought I would end by raising public awareness, recognizing we're here at FORCE, and what a opportunity to think about coming together and bringing the message out into our communities. So I thought I'd give a little data about some of the work we've done on raising public awareness when it comes to prostate cancer, genetic testing, male populations, et cetera. So to start off with, in terms of the evolution of genetic testing for prostate cancer, As you all are very well aware, prostate cancer is a major public health burden and impacts millions of males in the United States. So according to the American Cancer Society, prostate cancer still ranks as number 1 in terms of estimated new cancer cases diagnosed in 2024, aside from skin cancer, and the second leading cause of cancer-related deaths in U.S. males. When we boil the statistics down, 1 in 7 men overall will be diagnosed with prostate cancer in the United States per the current statistics. 1 in 5 black men will be diagnosed with prostate cancer in their lifetime. And when we factor in the millions of prostate cancer survivors, current estimates are that there are 3 million prostate cancer survivors in the United States. We see the huge need for impact and where we really can think about hereditary genetics, genetic testing, precision medicine, all of the things that we're going to cover today, the opportunity for impact. Especially because if we just boil it down, 5 to 10% of prostate cancer is inherited. So right then and there, we can see, if you insert that into those statistics, it's a lot of individuals just when we think about prostate cancer. So just to put this field of genetic testing for prostate cancer in a historical context, what we can see on a timeline is that genetic testing for prostate cancer really came onto the scene quite a bit later than genetic testing for breast and ovarian cancers and even for Lynch syndrome. So as we see in the late 1990s, early 2000s, BRCA testing came onto the scene for breast and ovarian cancer genetic testing, followed closely thereafter by genetic testing for Lynch syndrome. And this came at a time when genetic testing was focused genetic testing, so it was BRCA1 and 2, or it was the 5 genes linked with Lynch syndrome, and it really was primarily for risk assessment, was the nature of why testing was being discussed with patients. Prostate cancer genetic testing came several years later at a very unique time in terms of the clinical history. It came at a time when multi-gene testing was available, so beyond BRCA1 and 2, precision medicine had sort of burst onto the scene in terms of thinking of how do we integrate genetic testing to understand what therapies may be more optimal for patients. And then in 2024, even more expanded precision medicine indications. And so these things happened in fairly rapid succession in terms of prostate cancer and presented a really unique opportunity for a lot of the research that we've done and others around the country and really kind of globally. So when I graduated fellowship in 2004 and I joined the risk assessment program, originally I was here in the Philadelphia area. I was at Fox Chase Cancer Center at that time as a young faculty member, very much interested in learning more about the genetics of prostate cancer. I came out of a lab that was looking at trying to identify genes linked with hereditary prostate cancer and bringing this into the clinical context. So at that time, I distinctly remember a patient that I saw in 2006 who was a gentleman, age 56, who was diagnosed with a Gleason 9 prostate cancer. It was metastatic at the time of diagnosis to bone, and so very sort of, striking clinical picture. And his family history was that his mother had had and passed away from ovarian cancer, and sister had had breast cancer at a young age as well. And it was a striking clinical picture for a young gentleman to be diagnosed with metastatic prostate cancer with this family history and having strong suspicion that there was a genetic reason for what was going on in this family. And at that time, even BRCA1 and 2 testing in the context of prostate cancer was challenging. We did not have the availability to test his mother or his sister, and so we enrolled him in our research study to try to get the genetic testing done at least at that time. And I'm going to circle back to this because time has gone by and we have a lot more that we can offer our patients at this point in time. And in the course of my career, to see that evolve is very gratifying, and also to see how much more we have to go forward. So now this is taking a deeper dive into this timeline. And there was a lot that was happening together to bring us to the point of where we were with that sort of summary timeline that I showed before. It was the intersection between gene discovery, testing capability expansion, and precision medicine and precision management. So if we go to this first part of the timeline, we see that in the late 1990s that the story of BRCA began to evolve in the context of prostate cancer, recognizing that there were higher rates of BRCA mutations in males who had prostate cancer who were of Ashkenazi Jewish ancestry. There were then greater reports of BRCA2 in particular being associated with more aggressive prostate cancers over the years, and that's been confirmed and validated by multiple studies. And then tumor sequencing studies identified BRCA, particularly BRCA2, at higher rates in metastatic prostate cancers as well as time went by. There was a story of other genes as well. So Lynch syndrome came to the forefront in terms of thinking of, is there a connection between prostate cancer and Lynch syndrome in families? Some of that data has been, back and forth in terms of thinking of what really is the strength of that association, and thinking of which particular genes among the genes contributing to Lynch syndrome as well are linked with prostate cancer. But higher rates of prostate cancer began to be recognized in Lynch syndrome families. And then HOXB13 in 2012 was identified as the first hereditary prostate cancer gene. And I was just, thrilled. It was my mentor who I was working with as a fellow at University of Michigan, Dr. Kathy Cooney, who and her team working along with Bill Isaacs at Johns Hopkins that identified HOXB13 as the first hereditary prostate cancer gene. Now, along the way, there were also other types of markers that were being reported out, not only in the prostate cancer space, but along the way for breast cancer, colon cancer. These were the common genetic variants. So SNPs, single nucleotide polymorphisms, identified through these large genome-wide association studies. And there was an explosion of those studies that came about around 2005, 6, and 7, and have subsequently really taken off in terms of thinking of what are these common variants that confer low to maybe modest risk for disease in any given sort of marker, but this is where you might hear about polygenic risk scores, coming about in genetic testing. When are they going to be clinically useful? How do you interpret those results and things like that? So that came out of the GWAS story. And then a lot of the clinical testing data that was conducted then, because multi-gene testing became available, reported out on many other genes linked with prostate cancer, or what is the strength of the association with prostate cancer, and in addition, the precision medicine efforts. Now, testing capabilities as well really took off over this period of time. In 2011, 2012, 2013, I can't read that exactly, but around that time, the US Supreme Court ruled that naturally isolated DNA could not be patented, and that opened the door for multiple genetic testing laboratories to now offer not only BRCA testing, but also multi-gene testing, because next generation sequencing had also taken off in the same period of time. And then the precision medicine, era really came to the forefront with the capability of next generation sequencing. 2020 was a landmark year in terms of FDA approvals for 2 PARP inhibitors, and we'll talk about some of these in just coming up here in the talk. For approval for men with metastatic castration-resistant prostate cancer to be eligible for PARP inhibitors after progressing through initial lines of therapy. And this you can't read, but I'm going to show this in a later slide, but these are the current indications for targeted therapies in metastatic prostate cancer, just to show where we came to and the complexity of the field now in terms of thinking of precision medicine. So it really was, multiple types of initiatives and a lot of work by a lot of people, coming together to be where we are today. When we think about then, therefore, all of the work that went into identifying the genes linked with prostate cancer, what is sort of the data around that, the prevalence, the risk? What you can see here is just a couple of studies. There's been other studies that have looked at this in terms of the gene variant spectrum. We see that BRCA2 is fairly consistent in terms of the gene that has the highest prevalence in men, particularly with metastatic prostate cancer, followed by other genes that are in the DNA repair pathway. So that's a really important pathway to keep in mind when we think about therapeutics as well. Not only for prostate cancer, but also for breast cancer, ovarian cancer, pancreatic cancer, multiple cancer types where DNA repair and aberrations in DNA repair are being leveraged to treat these cancers. And so what you can see here is that the prevalence does vary based upon the gene, and thinking about this in the context of prostate cancer. In general, the rates are higher for men with metastatic disease. So the prevalence of germline pathogenic variants or likely pathogenic variants is about 10 to 17%. The seminal paper that was reported by Pritchard et al. Was in 2016. That reported about 11%. Depending on the study, you may have a range of about anywhere from 10 to 17% for rates of pathogenic variants, and these are mostly in DNA repair genes. What we also recognize is that with multi-gene panel testing, about 30% of patients, and particularly in the work that we've done, males getting genetic testing for prostate cancer, about 30% will have a variant of uncertain significance reported in their genetic testing. And this is really because we're testing multiple genes at the same time. So the more genes we test, the greater the chance of finding an uncertain result. And I think this is important because it factors into counseling models or pretest education models in terms of thinking of the likelihood that's 1 in 3 patients who could be having an uncertain result. So to just bring that up and to, put that out there, but then also to assess the uncertainty or anxiety that might come out of an uncertain finding for a patient. But now genetic testing has really become central in multiple ways, informing treatment for metastatic castration-resistant disease. There's an evolving role in terms of thinking of localized disease management, and then informing screening strategies and genetically informed clinical trials. This is just sort of a summary compilation of the genes that are on common prostate cancer multi-gene panels, which can be ordered for genetic testing, and thinking about the information that they give regarding prostate cancer risk, treatment, and hereditary cancer and familial implications. One big thing to keep in mind is that we see across the board that these genes are indeed having implications for hereditary cancer risk, not only for our patient, but also for family members. So this is something to really emphasize, especially when we're talking with treating providers or primary care providers or urologists or anyone who's really ordering genetic testing these days or thinking about genetic testing in their patients, to keep this in mind. But there really is variability as far as contribution to risk for prostate cancer, as well as thinking about prostate cancer treatment. So a pathogenic variant or a genetic mutation in a gene does not, it's really gene dependent when we think about what does this mean for risk for prostate cancer in a male or in their family. The standout gene really is still BRCA2, strongly associated with risk for prostate cancer and aggressive disease, has major implications for prostate cancer treatment in the metastatic setting, and of course, as we know, hereditary cancer implications. But again, when a provider is delivering this information to have a patient consider genetic testing, it does become important, at least in some summary way, to say not every gene confers the same risk for prostate cancer. And if the referral is for a treatment indication, it's really looking at which of those genes could be important, and that we may receive a result that may not be informative at this point in time, but could be in the future, and things like that. Now, when we think about then the impact, in terms of the clinical implications of genetic testing, we think about this along the spectrum of prostate cancer care. So all the way from already advanced or metastatic disease in terms of targeted therapies. Is there a role for genetic testing in the early stage, particularly active surveillance decision making? And then for prostate cancer screening, so in those screening discussions, how does genetic information factor in, and what are the current guidelines around that? And again, to emphasize across the board, there are hereditary cancer implications in any of these clinical scenarios when genetic testing is brought up. So when we pull all of this together, and this is just sort of a quick review of how all of that information has now been integrated into genetic testing criteria, because we know that there's clinical implications from the testing, hereditary implications, which for the patients and their families. And genetic testing guidelines have evolved over the years. We are working hard to simplify them and make them a little more accessible and also user-friendly for providers to actually access them and think about how to deploy this a little more broadly. At this point in time, the genetic testing guidelines for prostate, have lived in a couple of different NCCN panels. And so they were in the breast, ovarian, and pancreatic panel. They were in the prostate cancer guideline panel. And then part of it was in the colorectal panel when it came to the link with Lynch syndrome. So that makes it a little tough, to think about where should let's say a urologist go when they're thinking of genetic testing for prostate cancer. And so what we've been trying to do is bring that and consolidate it. So we're hoping that we're going to take a step forward, in terms of making this a little more harmonized. This was my take for this presentation, to make this a little more harmonized. So if we pull all of that into one slide, and where they agree and somewhat have some differences across the different guidelines is, was a little bit tough. But where they agree are the top categories of patients. So patients with prostate cancer, in terms of considering genetic testing for those individuals that have metastatic disease, node-positive disease, or high-risk disease. High risk by stage, by PSA at diagnosis, or grade group or Gleason score, indicating that those individuals really should be approached to consider genetic testing. Tumor testing that shows a genetic mutation in a cancer gene. Now, this is being done significantly more frequently to help identify genetic, pathogenic variants or mutations to help inform targeted therapies. But it could be that a tumor mutation is found in a cancer gene that could be germline or inherited. And so thinking about how then we confirm whether the mutation is only in the tumor or was actually inherited is the reason why this is factored into the testing criteria. And then, of course, having a relative with a known genetic mutation from the cascade testing perspective as well. And I put treatment decision-making up here because of the role of precision medicine in treatment decision-making, which we'll talk about coming up. This has become actually the #1 driver of genetic referrals at our program at Yale and across programs in the country as well. So really, thinking therefore of new models of how do we deliver care to our patients who need expedited genetic testing to help them make treatment decisions. We've been doing this for a long time to think about, surgical decision-making for patients with new diagnosis of breast cancer, how, for example, BRCA information can be helpful in that realm as well. And then there's the family history criteria for those individuals who don't meet any of these criteria. This could be for patients with a diagnosis of prostate cancer, say it's low risk or low stage, or individuals who don't have a diagnosis of prostate cancer but have a strong family history of cancers. And the criteria across the different panels, they sort of differ, but in trying to pull it together, really the reason that they're complicated is because they're trying to derive suspicion for sort of 3 of the key hereditary cancer syndromes linked with prostate cancer. So hereditary breast and ovarian cancer, and that's why the criteria are there with, greater than or equal to 1 blood relative with any of the following. So a young diagnosis of breast cancer, male breast cancer, ovarian cancer, pancreatic cancer, or with metastatic or high-risk prostate cancer, or 2 or more blood relatives with breast or prostate cancer at any age. So trying to be a little more wider, in terms of thinking of family history. And then for hereditary prostate cancer alone, looking at generational prostate cancer, earlier onset of prostate cancer, and sort of close relatedness of those relatives as well. And then the Lynch syndrome criteria are much more expansive because Lynch syndrome really does include a wide spectrum of cancers that are associated. So that's why you see several cancers listed here across these different guidelines, particularly the prostate cancer guideline includes this. But it can be complicated, but that's the reason why it's sort of laid out as it is. And again, we're trying to really consolidate this to make this a little more, adaptable and user-friendly going forward. So as we think about then, who should be identified for genetic testing based on the current genetic testing criteria, it really brings us to helping patients and providers understand germline genetic testing. So, I apologize if any of this is too basic, but I really wanted it to be, informative for the audience at large. So, one of the things to keep in mind is to educate patients and providers. And I do think it's really important to educate healthcare providers about different types of tests, the role of those tests, the types of information that we can get from these tests. And I spend a lot of my time doing that. But there's different types of prostate cancer related tests. And so particularly when we are in the community raising awareness about prostate cancer screening and genetic testing, we do need to define that there's differences. So there are screening tests. So this is for example, the PSA blood test for prostate cancer screening to help determine suspicion for prostate cancer. There's diagnostic tests such as the prostate biopsy, which is actually the way to diagnose prostate cancer. And then there's genetics. And so here, this is actually DNA testing, could be done on a blood sample or a saliva sample to help identify risk for prostate cancer, and these days is informing treatment, screening approaches, and could give us information about hereditary cancer risk as well. So, we often get patients who come to us saying if they've had a diagnosis of prostate cancer that they had genetic testing, but what they had was like genomic testing, like molecular profiling, of their tumor. That is not the same, as germline genetic testing. We educate our providers about the same thing, that we also talk about PSA being different than genetic testing. We also have to emphasize that, that this approach for whether it's screening or genetic testing is for the prostate, not for the colon, and because of the, colonoscopy also being, a rectal type of a test is not the same as a digital rectal exam for the prostate, and that the genes can be different. So, when we're talking, I've learned a lot over the years of working with community members because we want to make sure that we're delivering the information for good uptake, and that there's freedom to ask questions and things like that as well. So, so these are just some of the basics to keep in mind. And the overall purpose of genetic testing is really to help look for inherited genetic mutations, help men and their families or patients and their families understand cancer risks that could be uncovered based on the genetic results, to provide information on how to reduce or address those cancer risks or screen better in a more tailored way, and then provide information as clinically relevant for men with prostate cancer on how to treat that prostate cancer better. So this is really where the field of genetic counseling is really core and central in terms of delivery of this information, and I'll talk about that in just a moment. But just, a lot of the information we talk about, whether it's to our patients or out in the communities, is, understanding cancer genetics, kind of Cancer Genetics 101. When we think about prostate cancer, re-emphasizing that 5 to 10% of prostate cancer can be inherited. We talk about, what is a gene and what are we doing when we're doing genetic testing. So, genes being a piece of our DNA or pieces of our DNA that operate the cells of our bodies. We can think of genes as like a word in the English language. Words carry meaning. Genes carry signals for our cells. They tell our cells when to grow, when to die, and lots of other cellular functions. And so when the code of the gene or the word is wrong, and that's been passed along, the function of the gene can be disrupted, and therefore the signals are wrong that go to the cells. Now, a lot of these genes that we test for are called tumor suppressor genes. So like BRCA2, BRCA1, several of the genes that we test for are tumor suppressor genes. So their function is to stop a tumor, so to put the brake on cancer development. So if the code is wrong and the signal is wrong, that is no longer functional, and therefore the cancerous process can arise. So just helping to understand a little bit of that. And this is where family history information becomes really critical when we think about, what genes to really be testing for or included in the panels that we can test for these days. When it comes to family history for prostate cancer, really important to think about, prostate cancer, and if this information is known, metastatic disease, did someone pass away from prostate cancer, did they require a lot of therapy for their prostate cancer, surgery, then radiation, then hormonal therapy, gives an idea of that, okay, that sounds like it was more high risk prostate cancer. And also thinking then of generational, when we think about family history, I think everyone in our audience here knows this, but thinking of 3 generations, mother's side and father's side of the family, males and females on all sides of the family. So, we find that men tend to think of the males, women tend to think of the females, and so we need to, broaden our intake of that family history and encourage patients to do the same. And then to think beyond prostate cancer as well, because we know that these genes are connected. So to think about all cancer types, breast, ovarian, uterine, colorectal, pancreatic, skin cancer, melanoma, et cetera. So not only intake of prostate cancer family history. That's something that we do a lot of provider education about, is to emphasize, don't only just ask about, did you have a family history of prostate cancer, but go beyond that. And so this becomes really critical because of the hereditary nature of the testing. this is kind of what I was just talking about is, when we change the spelling of a word, you can completely change the meaning of the word, like tree to free, and that changes the signal. The same thing can happen in a gene, where the gene signal gets changed by the substitution or deletion, duplications, things that we're looking for in genetic testing, or it could render it nonsense, so it could change stop the signal from going out because it actually has no meaning when you change the spelling of a word. And here, when we're talking about germline testing, this can be performed on a blood or saliva sample. The genetic test is sent to a qualified genetic testing laboratory to perform the genetic testing, and the results are reported back to the genetics provider or doctor to discuss the results with patients and provide accurate recommendations and comprehensive recommendations for our patients. And then how this is done, this is a simplified process for genetic evaluation, but in the sort of gold standard way is to have referrals to genetic counseling. We often also get questions about what is a genetic counselor, and so these are master's level trained professionals who have then deep experience in specific clinical areas, and in this case we'd be talking about cancer genetic testing. And so genetic counselors are individuals who meet with patients, perform the detailed family history intake, discuss in the pre-test counseling session various elements that are important to understand about genetic testing, such as cancer inheritance, genes to consider based on medical and family history, what are the panel testing options, benefits and considerations of the various options and the types of results that could return, additional cancer risks that can be identified, impact of hereditary cancer risk for patients and families. The GINA law becomes really important to bring up, particularly for individuals who don't have a cancer diagnosis and are otherwise healthy, to think about could a genetic mutation impact their ability to get life insurance or long-term care or disability insurance, and to think about that before proceeding with genetic testing if that's something that is important, like crucial, in terms of financial stability and things like that. And as I mentioned, impact on therapy is a major driver now for us in terms of our patient referrals, and so running through this information with patients becomes really important. The genetic counselors order the genetic testing as well with various panel testing options, and then once the results return is to go over this information with patients about the nature of the results, the impact for the patient, and then cascade testing if a pathogenic or likely pathogenic variant is identified. We also know that the cancer genetics programs are getting really overwhelmed by the number of patients that need genetic testing these days, not only in the scope of prostate cancer, but across the board. And so we're really developing novel ways of doing this care delivery, so really building upon the basic principles of genetic counseling. We've developed a method at Yale called the Fast Track program, where we have genetics clinical coordinators, and so they are not master's level trained as genetic counselors, they're bachelor's level educated, and they come in and get intensive education by our genetic counselors to use a video, deliver this information, and expedite genetic testing for patients that meet NCCN guidelines already or that have a therapeutic need for genetic testing. And then once results return, if there's a pathogenic variant, those patients are disclosed by the genetic counselor, and all of the results are discussed at a fast track case conference such that results could also be disclosed by our fast track coordinators. It's been one of the most popular parts of our program. Providers refer to fast track a ton when they know that they need a therapeutic decision to be made or just for expedited testing. So we're looking to expand it now. So it's really thinking creatively when we think about genetics care delivery. Just to run through a couple of these, high priority genes, because these are now going to matter when we talk about the therapeutics, but we're all very well aware of this. So BRCA1 and 2, high risk of prostate cancer, risk for aggressive prostate cancer, particularly with BRCA2. For males, there's additional cancer risks, so this is education to understand that not only if the index reason is for prostate cancer, we could uncover risk for male breast cancer and pancreatic cancer and melanoma. And then for females, of course, also the risk for female breast cancer, ovarian cancer, pancreatic cancer, and melanoma. HOXB13, as I mentioned, was the first hereditary prostate cancer gene identified. Here, it's high risk for prostate cancer alone. At this point in time, there isn't data that supports that this is associated with other types of cancer risks, but there may be in the future. So it's linked with prostate cancer in families, generational prostate cancer, but very interestingly, there's strong data that it's linked with younger onset of prostate cancer. So for men diagnosed even in their 40s. And so, you know, as was mentioned, I also lead a program at Yale for called the Early Onset Cancer Program, and we're thinking about ways to address early onset of prostate cancers for men diagnosed under the age of 50 as well. And so there's a lot of unique needs, you know, for this population. And then Lynch syndrome, with multiple genes associated with Lynch syndrome, higher risk of prostate cancer, particularly for MSH2, in terms of some of the data that's been reported out for this. But as we mentioned, Lynch syndrome is linked with many other cancer types, as shown here. So a lot of multidisciplinary care that is needed for these patients once Lynch syndrome is identified, linking them with the right specialists. And what we have found is really trying to develop new navigation programs for these patients that have such, you know, intensive multi-specialty care that is needed so that they're seeing the right people and, you know, the healthcare system isn't a barrier. And so just really thinking about how to facilitate care for patients. And then, of course, as we know, you know, with BRCA2 being a key gene in terms of hereditary prostate cancer and for therapeutics, cascade testing becomes really, really important. And thinking about this in terms of genetic testing for, let's say, you know, a man's sons, but their daughters as well, you know, really have to open the mind about thinking, you know, in terms of for males and females, biologic males and females. And so, you know, keeping this in mind because the recommendations are very extensive in terms of just looking at BRCA2 pathogenic variants. As you can see here, you know, there's implications for prostate cancer, male breast cancer screening as well, which would start at age 35, pancreatic screening, particularly if there's a family history of pancreatic cancer, having that patient be seen by a GI specialist, particularly those that are specialized in pancreatic screening and imaging and talking about the pros and cons. Full body skin exam as well becomes important for addressing some of the melanoma cancer risk. But then thinking about, you know, cascade testing implications, it really does broaden whether we're thinking of males and females and across the board thinking of breast cancer management, ovarian cancer management, and in addition, thinking about pancreatic cancer, melanoma, and then prostate cancer as well. So that sort of sets the stage as we now move into the impact of genetics on prostate cancer clinical care. So back to this very simplified, you know, little figure here in terms of thinking of where is genetics being factored in for treatment, particularly in the metastatic setting. Evolving, more data is sort of needed to think about active surveillance decision-making and in screening discussions with the hereditary cancer implications that we've talked about across the board. So as we think about the impact of genetics on treatment, really, the area that has taken off is in the treatment of metastatic prostate cancer. So I'm going to run through a few of the trials that have been reported that led to FDA approvals for PARP inhibitors in particular for metastatic castration-resistant prostate cancer. Some of these drugs are shown here. So these are PARP inhibitors, olaparib, rucaparib, either alone or in combination with androgen sort of directed therapies, as well as talazoparib, which was also recently FDA approved in combination with enzalutamide. There's different indications in terms of the gene mutations, the clinical context in terms of when these drugs and combinations are recommended, and therefore the NCCN guidelines have really had to evolve to really accommodate all of this. The big thing to keep in mind is that this is in the context of DNA repair mutations. So. And what we're talking about here when we're talking about PARP inhibitor therapies is really leveraging this concept of synthetic lethality, of having the drug basically kind of take advantage of cells that are, have a deficiency of homologous recombination repair, so for example with BRCA2, and therefore they don't have the ability, so they've already got, they're compromised in terms of homologous recombination repair. The PARP enzyme would usually step in to help with some of these repair processes, and the PARP inhibitor is therefore stopping the second pathway. So it's two hits kind of happening at the same time for these individuals in terms of therefore leading to clinical activity. So one of the first studies that led to an FDA approval of PARP inhibitor olaparib was the PROfound trial. This was a study that was done in looking at the drug olaparib either alone or versus physician's choice for abiraterone or enzalutamide. Again, these are androgen-directed hormonal therapies in the setting of prostate cancer. They looked at these two arms in two different cohorts of patients. This was done in cohort A, which was looking at BRCA1, BRCA2, and ATM, and cohort B, which was looking at genes in multiple other DNA repair, involved in different aspects of DNA repair. So it was much more broad in terms of thinking of the genes for studying olaparib. And what they found was that there was improved progression-free survival and then subsequently overall survival with olaparib in these individuals, and they had failed prior lines of therapy in terms of their course of their care for metastatic castration-resistant disease. And the results of this study led to FDA approval of olaparib for patients with deleterious or suspected deleterious or germline mutations or somatic for men that had metastatic castration-resistant prostate cancer. And the approval specifically stated following prior treatment with abiraterone or enzalutamide. So this is as single-agent olaparib therapy. Then the Triton-2 study reported out the clinical activity of rucaparib, which is another PARP inhibitor. And this particular drug was looked at in BRCA carriers, but it was also looked at in non-BRCA carriers, but the approval indication is for those that carry BRCA mutations. And what the Triton-2 study reported out was that there was improved clinical activity for men that had metastatic castration-resistant prostate cancer who also carried a BRCA mutation with rucaparib. And this, again, was individuals who had progressed on prior lines of therapy, such as androgen receptor-directed therapy, and prior taxane-based chemotherapy as well. So two of these single-agent drugs approved in the setting of progression on prior therapy for mCRPC. Then there were two pivotal studies that were reported a couple of years ago that were looking at now bringing these therapies, such as PARP inhibitors, up front in the metastatic castration-resistant setting. So one of these trials is the Magnitude study. This was looking at niraparib, which is another PARP inhibitor, in combination with abiraterone, and looking at responses for patients that were either carrying DNA repair gene mutations, and the list of those mutations is shown here and below the graphic here. And looking at clinical responses, whether they had these biomarkers or had mutations in these genes, or whether they did not have mutations in these genes. And what they found was that there were superior clinical responses, radiographic progression-free survival for those individuals who actually carried mutations in these genes. Again, particularly in the subgroup that had BRCA2, BRCA1, but honestly it's driven by BRCA2 data in terms of thinking of those clinical responses. So there was significantly lengthened radiographic progression-free survival in these patients that carried mutations in any of these genes compared to standard of care abiraterone. A similar study was then also reported out at the same time called the PROPEL trial, and this particular study was looking at olaparib in combination with abiraterone for patients carrying a host of DNA repair mutations. And again, this was in the upfront setting, so looking at metastatic castration-resistant disease for individuals who hadn't received therapy yet, so in the upfront setting. And here again, there was improvement in clinical responses based on prolonged progression-free survival for those individuals who were treated with olaparib with abiraterone versus abiraterone and placebo in this upfront setting. And this one is actually irrespective of the marker status. So in essence, it was the results were saying you could treat any individual regardless of the marker status with olaparib or abiraterone. And so there's a lot of sort of ongoing debate or need to think about what are really drilling down on the clinical responses for individuals, for patients. Which patients might be optimal for selecting for specific therapies, upfront, beyond. It really has to fit into their clinical picture. to make this decision from a clinical perspective. And then TALAPRO-2 also reported out frontline therapy for metastatic castration-resistant prostate cancer. This was with PARP inhibitor talazoparib plus enzalutamide, and this again resulted in statistically significant improvements in radiographic progression-free survival versus standard of care of enzalutamide as first-line therapy in patients treated with enzalutamide and talazoparib with metastatic castration-resistant disease. So it's really opened the door in terms of thinking of options for treatments for these patients. I guess it's still hard to see, but these are the current NCCN guidelines for thinking about integration of PARP inhibitors in various scenarios. So what we have in the left upper panel is for patients who have no prior therapies as well, no prior hormonal therapy, and no prior docetaxel-based therapy, so taxane therapy. And in this case, there's indications for niraparib and abiraterone for patients who carry BRCA mutations, olaparib plus abiraterone, or talazoparib plus enzalutamide. So in terms of combination upfront therapies for patients that have not received prior therapies. Those remain for those patients that either had maybe one of those prior therapies, like docetaxel and or hormone therapies, and those are in this box over here and up here. And then down here, we have the indications for single-agent olaparib or rucaparib for those individuals that have had metastatic castration-resistant disease with progression on prior lines of therapy. And so, based on the original reports, so it really comes to this issue of what are the optimal ways to treat patients now with metastatic castration-resistant prostate cancer. And so, how far we've come from when we were back in 2006 and thinking about this, when we could barely get BRCA testing, for our patients. So that's in the metastatic setting. On the screening side, and I know the title of the talk was treatment, but I really want to talk about care, in general for prostate cancer. So when we look at screening for prostate cancer, the guidelines have also evolved in terms of how to think about genetic mutations and factoring that into screening approaches. One of the trials that was really influential in delivering data to think about the guidelines was the IMPACT trial. And the IMPACT study looked at clinical results from screening for male BRCA carriers versus non-carriers, where there were higher cancer incidence, particularly for those men who carried BRCA2 mutations. BRCA2 carriers were diagnosed at a younger age as well, and also were more likely to have clinically significant disease. All of these match up with the existing data regarding BRCA2. And so the current NCCN guidelines recommend that for men that carry a BRCA2 mutation to start their prostate cancer screening at age 40 versus the general population guidelines where there can be some variability, maybe get a baseline at 45, 50, things like that. But definitely this is younger than in the general population. The IMPACT study also reported out on prostate cancer screening in male carriers of DNA mismatch repair genes linked with Lynch syndrome. And here also there was there was findings of clinically significant prostate cancer, particularly for MSH2 carriers compared to non-carriers. And the positive predictive value of a biopsy was also higher in those individuals. And so based on some of this evolving data as well, the NCCN guidelines recommend prostate cancer screening begin at age 40 as well for DNA mismatch repair mutation carriers, basically for men that have Lynch syndrome. And this is now a part of the guidelines when factoring into prostate cancer early detection. Family or personal history of a genetic mutation is sort of factored there into the actual decision tree for thinking about prostate cancer screening. And what the guidelines say is for those individuals that carry mutations in a host of genes, the recommendation is for BRCA2 carriers to start at 40 and to consider decision making also starting at 40 for a host of other genes like BRCA1, ATM, CHEK2, PALB2, etc. And that goes back to one of the slides earlier where there was the range of risks for prostate cancer based on the genes that are tested. So it goes from like a stronger recommendation to a bit of a softer recommendation, but in general, bringing it up, to males to think about earlier screening. And there are some screening studies that are ongoing that are really going to be important to look at in terms of the report out in ways to screen better for male mutation carriers. One of these is at the NCI, and this is men at high genetic risk for prostate cancer. We actually do refer many of our male carriers there if they'd like to participate in a study. What they're looking at is not only PSA, but also imaging in the screening approach, so multiparametric MRI and things like that, and thinking how MRI can be incorporated into the screening approach for men that are at higher risk of prostate cancer. The Patrol study is another study that is looking at this kind of in a real-world setting where physicians can either do PSA and or incorporate MRI into their approaches. And so these are two studies to keep an eye on in terms of thinking of new data that might be coming forward for how to improve upon screening for male carriers. And then in the early stage setting, as I mentioned, it's not quite there in terms of thinking of active surveillance discussions. The first study was reported out in terms of thinking of, does genetic information help in terms of thinking of those men who may have progression of lower risk, lower stage prostate cancer? So active surveillance is typically recommended for individuals as a point, or I should say, is discussed with men in terms of those men that particularly have low risk, low stage prostate cancer as a way to monitor that prostate cancer. And this approach it's an invasive approach still, where there's PSAs that are frequently checked. There are either biopsies that are done based on PSA changes and or scheduled at certain intervals to keep an eye on the prostate cancer itself. And what they're looking for is upgrading of the prostate cancer. So say going from a Gleason 6 to a Gleason 8 or something like that on subsequent biopsies. And if that upgrading happens, that typically becomes the trigger for proceeding with definitive treatment, whether that's surgery or radiation. And so is there a way to factor in genetic information to get an idea of predicting who may have that sort of upgrading of biopsies and therefore be able to perhaps take those men straight to definitive treatment because there's a greater chance of that happening? So this particular study looked at this in 1,200 individuals and found that 289 of those patients were upgraded. By the time they got into the genetic mutation information, you can see the numbers fall quite a bit. But what they did find was that reclassification occurred in BRCA2 carriers, BRCA1 and ATM carriers, but that was really driven by BRCA2. So in terms of thinking of what would be the major drivers, and so the data what we're looking for really is more validation of this information, and there are studies that are going on to look and see how to incorporate genetic information in active surveillance discussions and approaches. This is hard to read, but really what we're showing is that there are many, many clinical trials that are going on looking at combination therapies, targeted therapies, either in combination with standard therapies or alone, whether in the high-risk setting or kind of earlier in the setting from metastatic disease. And so this is a really active area of work, and this field is really expanding. And so I think we're going to see a lot of information come out in the coming years to really expand upon our abilities for treatment of patients with prostate cancer or at risk. And then I'm just going to end with ways to help raise public awareness, because we have so much information now, and how do we bring this out to our communities and healthcare provider communities to really raise the benefit and the impact of genetic testing? So this is just like a summary of my research program. We have had long-standing efforts that have been going on, particularly in areas such as genetic access, dissemination, and population needs, as well as multiple grant-funded studies looking at ways to reduce cancer disparities and come up with equitable strategies for engagement in genetic testing. But I thought I would highlight a couple of the studies that we have done that were specifically looking at ways of raising public awareness through different things like podcasts and social media and different things like that, that we are now more and more listening to, or are ways that the public receives health information or looks for health information. One of these was the engagement study, and this was funded by a grant from the Department of Defense, where we looked at, one of the aims of the project was to develop a series of podcasts to talk about prostate cancer genetic testing. And this is available on Apple or Spotify, and I'm really not promoting, I'm just saying that this is out there for you. And we studied the use of podcasts to see, is it actually a good avenue for delivering information? I did this in collaboration. I was the principal investigator with my co-principal investigator, Stacy Loeb, who is at NYU and Manhattan VA Hospital. She hosts the SiriusXM Men's Health radio program as well, and really has been a major driver in bringing a lot of public awareness about men's health to by her work. So we co-hosted the Prostate Cancer Genetics podcast, and looked at some of the markers of usefulness of this for delivery of this information. And these podcasts included, not only we brought in experts to talk about particular areas about genetic testing for prostate cancer, whether it's from the treatment side, the hereditary cancer risk side. We brought in genetic counselors to talk about what this means for patients and families. We brought in a patient themselves to talk about their experience, and then there's his son came on as another guest on the podcast. So we tried to cover about 7 different areas. It was a limited series. And what we did was put this out and had individuals who were participating in a study tell us about, ease of, was this helpful, beneficial, increasing in knowledge? And what we found was that overall, there was increase in ease of use. Satisfaction was high with the use of podcasts for genetic testing information. There was a positive attitude towards it, and knowledge improved as well. What I thought was really important was that the perceived usefulness, that this was, the respondents felt that this was particularly useful for them or their families, came from Black, Hispanic, Latinx adults, and as well as individuals that had a family history of cancers. And so it really helped to think about, how do we bridge the gap across populations to help deliver information, in a novel way. Another study that we did, funded by a grant from the Prostate Cancer Foundation, was the Target study. And this was a national study, kind of an East Coast to West Coast collaboration. Again, with myself as principal investigator, co-principal investigator Stacy Loeb, and then we worked with Heather Chang, who is at University of Washington. Also, really, there's many studies that Heather is leading, Dr. Chang is leading for genetic testing of prostate cancer. She's one of the leads of the Patrol screening study as well. So it was great to collaborate across the United States. Dr. Leader is a population scientist here at Sidney Kimmel Cancer Center at Jefferson, and she and I have collaborated on multiple studies to think about genetic testing and ways to improve population access. And so one of the aims of this particular study, the Target study, was to increase population awareness. And here we were studying social media to think about, can this be a way to first assess, is there any public discourse happening to the degree for, and comparing it to breast cancer in terms of genetics, genetic testing, genetic awareness, and comparing prostate to breast cancer. And then to think about developing and testing a sponsored ad campaign to see if we could promote genetic counseling and testing or promote awareness about these things. So this again was sort of our starting premise and background, and so the team that we were working with actually has a lot of experience across the investigators to think about studies that look at the role of social media. So we also published on these results in terms of the use of social media to address gaps in public awareness about BRCA testing in prostate cancer. We first did a landscape analysis looking at social media platforms such as Twitter/X, Facebook, and YouTube, as well as looking at posts and videos. And what we found was that looking back over a 5-year period, that there were, as you can see here, significant difference in terms of the number of tweets that were about BRCA and breast cancer versus tweets about BRCA and prostate cancer. There was also a major difference in terms of comparing between, when we looked at some of these keywords, genetic testing and breast cancer, genetic testing and prostate cancer. And then in terms of looking at impressions and reach of those tweets. And then looking to see, what about Facebook groups and pages regarding prostate cancer and BRCA testing. What it shows that we have an opportunity here to think about ways of increasing public awareness because they had fewer average members and new members and posts compared to in breast cancer as well. So we then, this is a manuscript that's in progress, and so we haven't published this yet, but here we looked at trying to develop messages to help support social media-based delivery of prostate cancer genetics information. Here we developed sponsored ads to see which ads would function the best, that the public would then view the ads, take some screening questions, and then take a survey about information about cancer genetics knowledge. We had to user test the ads to make sure that they were relatable, that they included high-performing sort of metrics for images, uptake, clicks, views, impressions, and reach. And I learned quite a lot, in terms of working with my colleagues who are social media research experts. And then this was launched in terms of a social media campaign. 875 individuals took this survey after kind of looking at these the messages that were out there about prostate cancer and genetic testing. Two of the most engaging images were those where it was a group of diverse, racially and ethnically diverse males that actually had a lot of impressions and reach. The message that received the most engagement was breast cancer and prostate cancer may be related because they can arise from the same gene mutation in a family. So really bringing these key components together to help make the connection, and also thinking about having female users be another conduit to males, and thinking about ways to raise public awareness as well. So it was feasible. We did see that females were more likely to engage in the posts, and I think it's just really important to get a sense of like how we can then capture and leverage this information as we go forward. So it's just it's a very exciting thing to think about. But just to end out, as I mentioned, we had my patient back in 2006 with limited options for genetic testing or treatment. And here we are in 2024. I recently had a very similar patient at our institution, same 56-year-old male diagnosed with a Gleason 9 prostate cancer, and his mother had ovarian cancer and sister with breast cancer as well. It was eerily similar, and genetic testing included not only BRCA testing, but also panel testing at this point in time. And we had many things that we could then offer for this patient. And how much times have changed as we've gone forward from 2006 to 2024. So it really helped to think about how far we've come and how far we do need to go. So in summary, I know we've covered a lot of information, but really some of the take-home points are that genetic testing has revolutionized prostate cancer treatment, screening, and management. Hereditary cancer risks are critical to address for men and their families throughout this process. We've made a lot of progress in terms of thinking about the treatment for prostate cancer. As we see, there's many indications now for targeted therapies, but there's ways to go in terms of understanding clinical outcomes and optimal patient selection. And then, how can we come together to think about raising public awareness about the benefit of precision medicine across populations, and then to really, bring attention to reducing disparities as well as we do this, working together. So for the multiple studies that we have going on and initiatives, we have received several grants from the Prostate Cancer Foundation as well as the Department of Defense. I have many, many people to thank and acknowledge for each of these different studies. This is really team science as we do this work together. Definitely not do it alone. In particular, I would like to thank Dr. Amy Leader, who has been my co-principal investigator on many of these grants. So I will end there. Thank you very much for your time and attention.
Hello, can you hear me? Yeah. So does anyone want to come up and ask some questions? Try and keep it general if you can.
Hi, Dr. Giri. Scott Landman. I'm a force volunteer community leader for the men's virtual support group. Thank you so much for all the work you do. I have a couple of very general questions. One, to what extent do we know why than it should be?
Really good questions. To your first question about why would the prostate be, so susceptible or have such a higher rate of cancers, I don't think I can answer that fully, except to say that, there's a lot of sort of commonalities in thinking about influences over a person's lifetime, hormonal influences, and genetics. So they're common, for example, to breast cancer, as well. And so it's probably a multifactorial reason as to why is that even the case. But I think when we look at the underpinnings of why there may be these hereditary factors, a lot of the underpinnings are the same. And so it could be maybe hormonal influences and other things as well. But I would say that would be something we should explore, to look at. But to your other question about the expertise, in genetic testing or genetics programs, so specific expertise in GU cancer genetics. If you just specifically search for that, you may not actually see that many programs come up that have GU cancer genetics expertise. They are there. But with the expansion of the genetic testing guidelines, cancer genetics programs across the country are really actually seeing patients and evaluating men for genetic testing for prostate cancer. So it's a part of the overall kind of approach, for patients. But it is true, even when we have questions, we reach out to folks who are doing have this sort of built-in expertise, because there's a lot of expertise that is needed at times.
Okay, I have a question. So in the case of men, it seems BRCA2 mutations seem to be a much worse outcome for BRCA2, both in the amount and the type. So for men that have been fortunate enough, like myself, to be diagnosed at an early stage where the disease is localized, and always a big debate, no matter what you are, if it's early, do I get surgery or do I get radiation, is always a big thing. So when a man has a BRCA2 mutation, should he be thinking more about one versus the other, or is it the same outcome or risk whether you have a mutation or not for that?
Right. And that's where a lot more data is really needed. So I ask my urology colleagues and radiation oncology colleagues all the time when I'm with them, because I just want to know, is it now helpful? Do they feel that they're comfortable with enough data? It becomes a part of the conversation, in terms of the risks and benefits of surgery versus radiation therapy for definitive therapy. It's one piece of that information. And so, or active surveillance, when we think about that. But still at this point in time, it's factoring it into a host of other things. Their clinical picture, comorbidities, other things that factor into as well. Disease extent, things like that.
So now, I think my understanding too is with the BRCA2 related prostate cancers, there tends to be spread all through the prostate, versus if it's more of a sporadic prostate cancer, you'll have more discrete tumors. So it seems like focal therapies are they more in line when there's no discrete tumors, versus if you have a mutation? Is that necessarily a way to go, because is there a lot of microscopic disease that's not being picked up on imaging?
Right. Well, and I think some of these studies, like the MRI-based studies, are lending a lot of data, because we didn't have that sort of picture of what these BRCA2-related prostate cancers look like, how multifocal they are, versus a single spot, of cancer in the prostate as well. And so those imaging tests are being done a lot more frequently, even at our institution, to think about, okay, because there's a mutation identified, we need to approach it in sort of assess the approaching of the way that you treat the cancer. But it's still it's in evolution. It's not like you would get the same response if you interviewed multiple providers.